Namaskar everyone and welcome to today's edition of Gazali. Today we have with us one of Goa's illustrious sons, Dr. Suraj Kamath, sitting by my side, who was my classmate in college and later on in medical school. He left Goa in 1988 and joined the famed Baylor College in Texas and passed out from there as an cardiologist. He does mainly interventional cardiology. Let us now ask Suraj to tell us what he does in the US.
Thank you, Bose. Hello, everybody. I studied here back in and finished in 1988, and then went to Houston, Texas. Baylor College of Medicine is where Michael DeBakey is from, and I had to repeat some of my medicine from here, then did cardiology, and then a year of interventional cardiology. Most of my time is spent opening up arteries,
Right.
and these arteries could be of the heart, of the vessels, of the
Yes.
aorta,
Yes.
or the legs. In fact, more than 70% of my time is actually spent saving legs from amputations.
All right. So initially all these were done surgically, right? So
That's
now the endovascular technique has taken over. That means you don't have to open up the patient. You access the patient to a small little needle prick.
That's correct. So what we do is we usually, for the procedures that we do in the legs, we go through the femoral artery, which is an artery in the groin, and from there through tubes we pass instruments from within the pipe, the
Right.
blood vessels,
Yes.
and open them up. We have balloons and stents, but there are newer technologies that shave off blockages
Right.
by actually cutting out the blockage from within, or if we find very hard calcified blockages, we drill off the blockage and provide blood supply to the legs. This then saves the legs from being amputated from gangrene.
Right. At some stage, Suraj, I wish your expertise can come to Goa, and I will see that you come over to pass
God
this
willing,
expertise
God willing,
to
why
us.
not?
Yes. I think that what you're doing is wonderful, trying to save limbs, trying to save hearts. Tell us a bit about how you initially check for risk factors in heart disease.
So, I mean, when you look at the heart is a very important organ. It pumps 5 liters of blood per minute
Right.
when we are just sitting here talking.
Mm.
But if we get excited, if we run, if we walk, exert ourselves, the heart can go up to 20 liters per minute.
Right.
Now, the muscle of the heart requires blood supply to pump
True.
for this. And the vessels of the heart are on the surface of the heart, and they provide blood supply to the muscle. If you get a blockage of one of the arteries, these pipes are called coronary arteries, and if you get a blockage of one of them, then that area of the heart will not get blood.
Yes.
And usually people would get a chest tightness or a pressure or a heaviness, but they can also get jaw pain or a
Left arm pain. Tightness.
left arm pain or a throat pain or an arm numbness
True.
or even an indigestion.
True.
So they think it's gas. But the beauty of, or the thing that says it's the heart is the fact that it comes when you exert yourself,
Right.
and when you just stop what you're doing and relax, then it goes away. And that's what we call angina.
Right.
Now, a different issue is
Yeah.
a heart attack.
Right. What's the
And-
difference between an angina and a true heart attack?
So when you have a blockage, and blockages come up because of the presence of risk factors such as diabetes, high blood pressure, or high cholesterol, or hereditary factors. If your
Right.
parents have coronary artery disease, there's a high chance that you will have coronary artery disease. And aging. I mean,
True.
if you live long enough, you'll
You are bound to
degenerate
get-
your vessels.
Yeah, bound to have some cardiac
Some
problem.
troubles.
Yeah, true.
So when these blockages come up and they restrict blood supply, but blood is still going through, then all that happens is you get angina that is usually exertional when you walk or
Strain.
strain yourself. But if when the blood rushes past a blockage, if it gets a rough surface, the blood tries to repair that rough surface by making a small clot. But if that system goes out of control, you'll get a clot that blocks up the vessel totally. And these vessels are really small, like 3 millimeters.
Right.
3 millimeters is a really small vessel, and
Tiny.
if it's 50% blocked, it's 1.5 millimeters.
Right. Smaller than a refill of a ball
Definitely
pen. Much
smaller than a refill of a ball pen. So what happens is, this, when it blocks up suddenly with a blood clot, that's a heart attack.
Right. So tell me something now. They all say there is a golden period about a heart attack when you should reach the cardiac service as soon as possible. Tell us something about this.
So now, the heart attack issue is one where time is muscle. So if you can get to a hospital as soon as possible, the more of the heart muscle will be saved if they can provide blood supply to that area.
Right.
So 6 hours is the best time to come in, but the earlier you come in, within 1 hour, within half an hour, the easier it is to open up the vessel.
Yeah, yeah.
Up to 12 hours is the limit given. If
Right.
you arrive at the hospital after 12 hours, then
There's no
it's
chance
a
of
done deed.
saving
You
the
can't-
heart
you-
muscle.
You cannot save it.
Right.
And so the two therapies that we use, one is thrombolysis, which is essentially a clot buster.
Right.
It's something that we give into the vein. It goes and dissolves the
blood
clot.
clot. Yeah.
And the other is take the patient directly to the cath lab and open the artery out with balloons and stents. And for that, you have to have the cath lab available and ready,
Right.
so that you can rush the patient in.
Can you do both things together, or it is done sequentially?
That's a very good question, and the answer would be that previously we used to do both together. Nowadays we know that if you have a chance of doing angioplasty within a certain time frame, 1.5 hours or so, it's better to
Better
do
to-
angioplasty.
So it's a
If
better
it's beyond
salvage.
1.5 to 3 hours, then it's where you can get a cath lab open. It's
Right.
far better to do thrombolysis. The problem with the clot buster is, in about 3 out of 10 people, it doesn't work.
Doesn't work. But tell me, on the other hand, is it easy to get a lab open, cath lab open at 3 o'clock in the night or 1 o'clock at night?
So that's a problem with logistics, in the sense that the hospital has to provide the staff and enough staffing so that they can come at night, and you should have enough doctors where, let's say a doctor comes at night, then the next day he's got to work,
Right.
and then the next night again another patient comes. So how can he survive?
Difficult, very difficult.
So you have to have enough doctors to sustain such a program. So that's why it's a very good thing to have, but logistically you have to have that much staff.
Tell us something, Suraj, about now trying to have targets, for example, for the risk factors that you just mentioned. Are there any targets, like people should have a certain amount of blood pressure, people should have a certain amount of cholesterol, people should have a certain amount of diabetic control?
So previously, the lower the blood pressure, the better it was. And so if we had a patient with hypertension where blood pressure is above 150 in the higher number and above 85 in the lower number, we would want those numbers to be 120 and less than 80. Now, depending on age, we don't want to lower an older person's blood pressure too much.
Right.
But at the same time, generally speaking, we want the upper number to be less than 140,
The
and
upper
the systolic blood pressure to be less than 140, and the diastolic blood pressure, which is the lower number, to be less than 80.
80.
Okay, and that's an appropriate target. And if some people can tolerate lower and have better control, so be it.
Okay, can you repeat that in Konkani now? कोंकणीन आमचे भाषण सुरज सांगतो.
प्रेसावचे अशें आसा, वयलो एक नंबर आसता सिस्टॉलिक ब्लड प्रेशर, तो 140 सकयल आसूंक जाय, 140 सकयल आसूंक जाय, आनी लोअर नंबर जो आसा पोंचो नंबर तो 80चे सकयल आसूंक जाय, आनी तेन्ना तुजो ब्लड प्रेशर कंट्रोलार आसा.
बरोबर.
आनी अशें पळोवंक जाय की एक दिसाकसून 6 वरां 8 वरां कंट्रोलाक आनी उरलेले टायम नॉन कंट्रोल आसल्यार बरें न्हय.
आख्खोच दिसान
कंट्रोलार आसूंक जाय. वयर सकयल जातात ब्लड प्रेशर.
बरोबर. आनी कोलेस्ट्रॉला बद्दल
सो कोलेस्ट्रॉल प्रिवियसली जे कोणाक काळजाचे आसा ओके नाल्यार साखरीचे आसा आमी टार्गेट दवरताले LDL cholesterol. LDL म्हणल्यार लो डेन्सिटी लायपोप्रोटीन. That is the bad cholesterol.
बरोबर.
And we wanted that level to be less than 70.
सो वायट कोलेस्ट्रॉल आहा पळय तो तितलो कमी दवरपाक जाय.
तितलो कमी दवरूंक जाय.
बरोबर.
पण आतां कितें आसा आमी ताजे परस कमी दवरता. जशें की we don't care about 70, we would want it to be, even if it's 40, we don't care. Because when you have heart trouble, you've had a heart attack, or you have known heart disease, or you have diabetes and heart disease, or diabetes alone, we would like to give you a big dose of a cholesterol medicine from the very start.
बरोबर.
So the higher the dose of the cholesterol pill that you can tolerate, the better you will be. It'll decrease your risk of having a heart attack, decrease your risk of having a stroke, and keep you doing better.
What about what's the role of exercise?
So naturally, if you're fit and you're walking every day and exercising every day, your heart and your body will have better tone to it, and you will survive a heart attack better.
Right.
Exercise by itself will not prevent a heart attack. To some extent, it might keep you healthier, but the major effect also would be that you will feel your angina sooner.
Right. Does it develop new blood vessels to the heart if you exercise?
So, very good point. So now the other thing is, let's say you have a blockage and it keeps getting tighter, but you keep exercising. Then, because of this constant pressure on the heart to work and get blood supply, the heart remarkably has the capacity to develop side branches to that area with the blockage.
Right.
And we call that collaterals. It's like you making your own bypasses. That's why we find people who've never had a heart attack, who have a 100% blocked vessel, but everything's working well.
Yeah, a lot of additional vessels.
Yes.
Taking up the brunt. Tell me, there's another risk factor today they call homocysteine. How important is that? So, everybody is trying to do homocysteine levels in the blood.
So, the homocysteine is related to the folic acid metabolism, and high homocysteine levels are correlated with a higher risk of making blood clots.
Okay.
Okay. So, what happens in this situation is your risk of a heart attack goes up. So that's why it's a marker. So you need to take folic acid to get your homocysteine level down. There are other genetic diseases that we still don't know what to do with that increase your homocysteine level, but that's for another discussion.
What is the role of aspirin? Today aspirin is available over the counter, anyone can buy it. You don't even need a doctor's prescription.
81 milligrams of aspirin should be taken by all people who've had a heart attack before.
So 81
milligrams
a
day. Okay. All people who've had a heart attack
must take it.
No
two ways about it.
Now, if you've been diagnosed with coronary artery disease, some blockages of your heart, and if you've been diagnosed with diabetes and coronary artery disease, you have to be on aspirin.
Okay.
Just there's no two things about it. Now, for some people who have ulcers, and we get coated aspirin, but if you have ulcers, then the alternative to aspirin will be clopidogrel.
Clopidogrel. Okay.
Okay.
What is today's role of smoking? I think smoking has become a little less in Goa, but I think still you can advise people on smoking.
So when I look at smoking, you have to. There is no beneficial effect of smoking. Science has not shown anything that's good about smoking.
Right.
And some people. So the first thing is smoking is bad. Very bad.
True.
Okay.
Yeah.
Now, as far as the heart's concerned, it promotes both the risk of making a blood clot and the risk of making more blockages.
Right.
Okay. So let us consider this. If one pack of cigarettes costs 250 rupees,
right,
that's 20 cigarette box, and you smoke a pack a day, then that's 91,250 rupees a year, close to a lakh a year.
1 lakh.
1 lakh वर्षक एक पैक तो smoke ke liye. So ata tezar parishi, you're paying 1 lakh to try and have a heart attack.
Right.
That's not a good buy.
Okay.
You should have better use for your money than blowing it up in smoke.
On smoking. What about now? You're saying things like anti-cholesterol agents. Are any newer drugs that being used?
Okay. One more thing about smoking, I'll say, is sometimes people give the argument, I've smoked for 25 years,
Right.
why stop now?
Why stop now?
Within 1 year of stopping smoking, the heart vessels and other vessels in the body heal.
Is it?
So your risk of heart attack
That is
goes
something
down.
even I didn't know.
Right. So
yeah.
what happens is there's some healing that happens where
Excellent.
your risk starts going down. Within 5 years, your risk of lung cancer goes down.
Right.
In other words, see, the body is forever healing. We don't have the same organs
So
for the
it's a continuous
things change.
evolving structure.
Also importantly, we lose 1% of our lungs per year after age 50,
Okay.
just because we are growing older.
Older.
Okay?
Okay.
So now, if you arrive at 50 years of age having smoked and lost 50% of your lungs, which is fine, you can still tolerate your life
Right.
well, but you continue to smoke, you have a pneumonia, and then later on, when you reach 75, you reach only 20% of your lungs,
So you're incapacitated.
you're going to be in trouble. Every breath will be a struggle. And every single patient I know that has reached that stage wish that stopped smoking 20 years earlier.
20 years earlier.
Now, the beauty of stopping smoking is the lungs heal and you get about 10% of your lungs back. That will be good for you.
Long term. Tell me one thing, Suraj. There's, especially in Goa, everybody nearly, I can say, 90% have a drink. What is the role of alcohol? Because some studies in Europe say red wine is good, some studies in America say it's not that good, but what's your take on that?
So, alcohol in general, and it's not red wine, it's any alcohol, ethyl alcohol in beer, in wine, in whiskey, doesn't matter. 1 or 2 drinks a day is supposed to decrease your risk of a heart attack
That's good news.
and decrease your risk
Okay,
of dementia later.
I see.
Now, the problem is, this is not advice for bevdes. If someone's prone to misuse alcohol, overdrink,
Then
or
obviously,
say, you know, I'm not going to drink for 5 days, I'm going to save all of that for the weekend
For
and
the
drink
weekend,
only on Saturday, Sunday,
binge drinking.
then this is not advice for you.
Okay.
Now, it's 2 drinks for men and 1 drink for women
Okay.
because of difference in organ size and body weight.
Okay.
And that's what is useful. Now, this does not mean that I'm prescribing people that they should go out and drink every day.
But
This is what the studies show.
Okay.
I don't drink every day.
So roughly how many ml of alcohol a day?
So it's 1 peg. How much
One
is
peg.
1 peg? It's
That's
60 ml.
60 ml. Yeah.
60 ml.
Right. So 60 ml a day is tolerable.
Should be tolerable.
Okay. What are any other risk factors that have come lately? Any other risk factors?
So you brought the conversation about cholesterol.
Cholesterol.
And just this week, the Lancet published a paper that said that the side effects of cholesterol have been heightened so much,
Yeah. Overemphasized.
overemphasized. So now what happens is, if 10,000 people are treated, 1,000 will benefit from cholesterol, an absolute benefit of a decrease of heart attacks, strokes and death.
But the rest have made profit for the drug companies.
Well, you get them all generic now, so there's no problem. Okay?
Okay.
Now, what's the risk of side effects? A maximum risk of side effects, if you take it, is around 10 to 30 out of 10,000. And in fact, the 10% benefit that you get, meaning 1,000 people will have a lower risk, it's already accounted for that, you know, some of them have side effects.
Is it justified for the rest 9,000 to have side effects? Especially liver side effects.
So the liver side effects, no, actually the liver side effects are the most overemphasized.
Yeah.
In fact, in the US, the FDA has taken out the requirement to check liver enzymes.
function no longer required.
We don't
to
check
be
liver enzymes anymore.
Okay.
Main thing is all the side effects of a cholesterol medication
Yes.
are reversible. A heart attack or a stroke
Yeah, it's
is not reversible.
True. So still the advice is take your
yes,
anti-cholesterol.
take your cholesterol pill if that's what, if you have diabetes, if you have high blood pressure, if you are a smoker, have coronary artery disease, vascular disease, then it's worthwhile taking a cholesterol pill.
Right.
Now, when we talk about vascular disease, so how did I get into peripheral vascular disease?
True.
Because we found out that's an easy way to know if you have coronary artery
Right.
disease.
So anyone with having
Blockages in
blockages
the legs will have blockages,
in the heart.
have a good chance of having
Right.
blockages in the heart.
Right.
So that was easy to do.
Hmm.
So our thing would be that if we could diagnose peripheral vascular disease, then
Yes.
we were more aggressive in diagnosing coronary artery disease.
Right. So now tell me, Suraj, for every patient of, for example, limb blockages, do you necessarily do a heart coronary angiogram?
So usually we would do a stress test, but sometimes they cannot walk because of the pain
Because
they
of the
have in
limb
their
pain,
legs.
yeah.
So we do sometimes what is called a chemical stress test. But
Yes.
if we see abnormalities in the EKG or any other trouble, and we know beforehand that they have a high likelihood of having blockages, we go ahead and do a coronary angiogram.
Yes, okay. And one small thing, Suraj, there are a lot of people today who want to do non-invasive study for the heart. Like they will ask for a CT angiogram or they will ask for a thallium scan. Where do you place this investigation, like for a normal person who comes to you after an angina asking, doctor, can I have a CT scan instead of having a coronary angio?
So a CT angiogram, so if you have a patient where you are more or less absolutely sure, so we call that high probability,
Right.
that this patient is going to have a blockage. You listen to the patient, you talk to the patient, look at the EKG, feel, this looks like you're going to have a trouble.
Right.
Then a coronary angiogram is the best test.
Right.
You don't mess with anything else. But if you have intermediate risk, where we think maybe you'll have a blockage,
Right.
then you go for one of these tests, either with a stress test, or sometimes you can go directly to a coronary angiogram.
Right.
Now, the stress test where you just walk on a treadmill is not as useful
Accurate.
as having a nuclear stress test.
Right.
So now, nuclear stress test gives you radiation, and an angiogram gives you radiation.
Extra radiation.
A
Yes.
quick angiogram could be much less
So
radiation
the
than a
radiation
nuclear
is
stress test.
much less in a invasive angiogram.
An invasive angiogram, we go in, take pictures.
Right.
It's much less than doing a nuclear stress
So you don't get that number of X-rays.
test. That's right.
Yes.
So there is a debate about
Okay.
this.
And just to end, Suraj, tell me what advice you would give people, for example, who have had a heart attack to carry out after they are in the recovery phase.
So the main thing you first is medical therapy. You
Right.
have to have your aspirin. Sometimes your doctor will prescribe you a second antiplatelet agent like Plavix
Thinning. They just cause thinning of the blood.
for thinning of the blood. Usually you'll have a beta blocker
Okay. That,
like metoprolol,
okay. That slows the heart.
and you'll have an ACE inhibitor.
It controls your blood pressure.
Controls your blood pressure and lets the heart work less.
Less. Okay.
And you have to have a cholesterol pill.
Right.
It is just wrong that someone after a year of a heart attack stops a cholesterol pill.
Right.
You have to have it for life.
So lifelong you're on cholesterol.
You're on these pills.
Okay. What about your diabetes control now?
So
Do you have to have it tight, or can you relax, say, about 180, 170 levels?
so usually we check diabetes by looking at something called a hemoglobin A1C.
Yeah.
So hemoglobin A1C around 7 is our target. That's
Yeah.
a very important target to learn.
Okay.
Now, we do not like tight control because if your blood sugar falls and you get dizzy or you pass out,
Yeah.
then you are damaging your brain there and then.
Right.
So tight control where people get hypoglycemic, sakar samki devli dalar,
Barabar.
that is not good.
Yes.
Samke white, because here you are trying to protect your brain over the long term by controlling your diabetes.
Yeah.
But if you are damaging your brain there and then with a low blood sugar, that's not good. So
Not
tight
advisable.
control is not supposed to be on
Okay.
the cards.
So in effect, you have to control your cholesterol.
Yes,
You have to control your diabetes, not too tightly.
not too tightly.
Control your blood pressure.
So tightly means, so let's talk about
Yes.
this. One more sentence
Yes.
on it.
Yes.
When you say not too tightly, it gives people license to say, okay, I can have
Yeah.
it a little high. No. It has to be controlled with a
Okay.
hemoglobin A1C of 7,
Okay.
but not where your blood sugar is low.
Okay.
which means you can't miss a meal, you take a pill, you can't stop
Can't
eating.
stop anything.
You've got to be regular with your timing of the meal.
And how often do the chaps have to recheck their hearts? I've had a heart attack, say, last year. When is my next checkup for the arteries to see whether they are reblocking or what change is happening?
So, in someone who is symptomatic, we
Yeah.
would go and check right away. Anybody who's had a heart attack before, that's a high risk person. So, anytime they are symptomatic, we would do a stress test or even do an angiogram to see what's going on. Okay. If they are doing well and asymptomatic, at least the first year of it really depends on the coronary angiogram.
Right.
If they have blockages we are watching and haven't opened out, then
Right.
you do a stress test almost yearly, but often enough every 2 years.
Excellent. I think we have covered everything nearly that the heart has to give us. And with that, I think we'll bring that to a close. Thank you very much for listening to this program. And I'm sure this advice of Suraj Kamath has come in very handy and informative to all of you listening. Thank you.
I'm honored to be on this program and thank you very much for listening to me.